Good morning. I want to welcome all you to the session on women's health and wellness this morning. We want the session to be informal, educational, and we would also like you to be a part of it at the end after both of our speakers have finished. If you have some questions, Caitlin has some cards in the back if you would like to write your questions, or after we're concluded, if you have the question, please stand up. I will go ahead and repeat the question so everybody can hear them, and then we'll go from there. I have two wonderful speakers today that are known internationally, nationally, and in the state of Florida. Our first one is Dr. Elsie Crowell, who is president of E.B. Crowell and Associates, a consulting business with expertise in health policy, women's issues, insurance, HR management, and organizational development. During her 30 years of service with the state of Florida, she served as a number of top-level positions, including Florida's Insurance Consumer Advocate. Dr. Crowell served on the Florida Commission on the Status of Women as chair and a member for 8 years. She has taught critical health care issues and American Public Service at the Florida A&M and Florida State University. She's a board member of Florida Chain, working to increase across access to affordable health care. She currently serves on the Tallahassee-Leon County Commission on the Status of Women, Girls. She serves as chair of the first Women in Workplace Summit and is a member of the Economic Security Committee. She's a recipient of numerous awards, and we're so happy that she's with us today. Our second speaker, Dr. Judy Sedgman, has been dedicated to sharing the principles of mind, consciousness, and thought professionally for more than 30 years. Dr. Sedgman has worked over the years with many practitioners of the three principles throughout the United States and around the world. For 12 years, Judy served on the faculty of West Virginia University School of Medicine and was a director of the institute dedicated to innate health. She developed and taught courses for the master's program in public health, and she's still an adjunct professor with West Virginia University. Dr. Sedgman returned to the area and served as director of Institute for Public Policy and Leadership at the University of South Florida, Sarasota, Manatee. Today, she devotes herself to global outreach and innate health through her own consulting practice. I'd like to first introduce Dr. Elsie Crowell.
Good morning. It's a pleasure to be here, join you at this Commission on the Status of Women, which I've been so actively involved in for many, many years. So it's a pleasure to be here. The first thing I think about when we talk about health and wellness, we always ask the question that seems fairly simple, but becomes complicated as you listen to people. And we talk about, well, what in the world is health? And some people said, well, it's the absence of diseases. Others say it is peace and enjoyment and relaxation, particularly for those of you who have this window over here where you're looking at the water. There's relaxation when you think of something like that. And in my years of teaching and working and researching, I've been more curious about this definition of health, and I've been impressed really with the Robert Wood Johnson Foundation and what they do and what they talk about in terms of what is health. So I'll go ahead and just talk a little bit about Robert Wood Johnson. Now, I will acknowledge that I have no contracts with Robert Wood. I get absolutely not $1 from them. I'm just impressed with the work that they do. And they also put their money into much of these efforts that has to do with health. So one of the things that he talks about is health outcomes. His model is somewhat different from what we see from the CDC, the Center for Disease Control. They focus perhaps a bit more on the clinical care of health. And when you look at his model, where he looks at clinical care, he's got that at just 20% of what we call a quality of life. The thing that makes a difference in terms of his model, I think, is the social and economic factors that many times are left out when we talk about the quality of health. Here he talks about education, employment, income, family and social support, community safety. Those are the kinds of things where you don't see that drill down, if you will, in that the Center for Disease Control model. They have some of it there, but I think more and more now we're starting to look at health in a more comprehensive way rather than just medical care, clinical care. We look more now at health behaviors, what may be causing some of the issues, problems that we do have. And one thing we've known for many years is the effect of tobacco use, the lack of exercise, alcohol, drugs, sexual activity. And it's kind of interesting when you look at the way he ranks the states. He looks at each county, so he drilled down in each county, and I like to have the students take their particular county and kind of look at it and tell us what they think is going on there. In Florida, you'll look at the healthiest county to be St. Johns County, and the least healthiest to be Union County. Now, some of you may know where these counties are, but for a fact, Union County is probably one of the poorest counties in the state of Florida, least access to health care. That's the kind of pattern you start seeing, and you start to notice the variations and why they're ranked the way they are. And each year that they do this, they look at other factors. Coming up, they'll be looking at children in poverty. They'll be looking at injuries, hospital stays, and those kinds of factors that they will be looking at to do that. So I just thought that talking about that briefly, about this overall business of health and wellness, is that we do have to look at it in a comprehensive way, more totality. And then what they do is they can go to each county and say, here's some policies, programs that you might look at. And in many cases, they're funding these programs for your counties if you happen to be among those that are awarded those grants. So that's why I'm impressed with what they're doing, how they explain to you what health really is, and then they're willing to finance some of those programs. One of the patterns we notice is that income play an important role in the status of health. When you look across the counties, particularly in Florida, you notice that the income is really high in the counties that are ranked high, and is really low in the counties where you got more poverty, what have you. You'll also notice that sexual activity is higher in the counties that have a university or universities. We've looked at it in Leon County, we've looked at it in every time you look at the counties where they have a heavy concentration of college students, you see something different, and not only in terms of sexual activity, but in terms of income, because a lot of college students do not work. So when you take the college student factor out, you see something very different when you talk about health status in the county. So I'll encourage you, they do it on every state except probably Rhode Island and a couple of other states, but I would encourage you to take a look at it. And I had a little PowerPoint that showed the healthiest in California. I did a few of them, so if you're in here, that you might recognize why Marion County in California is considered the healthiest and why Lake County is considered the least healthiest in California. In Texas, and I can't pronounce your county here, but the healthiest is Presidio, or however you pronounce that. And then the least healthiest is St. Augustine in Texas. Louisiana, you've got your healthiest as being St. Tammany, how you pronounce that? Parish, and then your least healthy is East Carroll. New York, your healthiest, Livius. So if you look at your counties, you might have some idea about why that is, and also look at the ones that are at the lower end that might be beneficial in terms of looking at it. So that's just kind of an introduction in terms of what I wanted to say about Robert Wood Johnson. Now I want to talk really more about the role and significance of women and why we think women are so important when it comes to health, not only as individuals, but the role they play with families, the decisions they make, and how amazing it is that women do so much for so many others and still maintain their sanity, is what I call it, because it really is amazing. I do Medicare counseling for seniors, and invariably it's the woman that comes to get information for the husband, for the mother, for the friend, for whomever. I rarely have a male that will show up, and if he does, he comes with the spouse. And so women play an important role here. They have a longer life expectancy. Now that gap is starting to close here because for whatever reason, we're seeing that maybe there's some adjustment there in terms of women's life expectancy. Women use the healthcare system more often. They cost the system more because they use it more often. And that is why it's so important for us to focus on women. The largest number of caregivers that we have in this country, again, are women, and often not paid for the services that they provide. And that's a pretty tough job as a caregiver, be it at home or be it for someone else. I said earlier, they make the majority of the healthcare decisions. So if I want to talk about anything that has to do with making a decision about healthcare, then I'm going to target women because they're the ones that's got to listen at what's going on, pay attention, and then try to, in their own mind, and they're intelligent people, make some decisions. Women are the largest enrollees in the public health system, meaning Medicare and Medicaid. They significantly make up the larger number. So they would need to know what's going on with Medicare changes, what's going on with Medicaid, because they, in fact, are the enrollees in there. Now, the previous, I call it previous barriers, but they're still not really previous when we look at that. But as many of you know, there have been gender ratings up until the Affordable Care Act was passed. Some women didn't even know that their premiums were higher because they were women. Some women didn't even know that there was more or less a rider for pregnancy. You know, you kind of had an extra little thing on your policy if they thought you were at that age range that you might get pregnant. That's gone away now. Many of the women before the Affordable Care Act pretty much got their coverage as a dependent, maybe on their spouse's policy. And it was pretty difficult for a woman to go out there and get a policy by herself. Even if she had good income, they saw her as being an individual with pre-existing conditions. Now, half of the women in this country are deemed to have pre-existing conditions, and that has been defined largely by insurance companies in the past. You know, what is a pre-existing condition? But I talked about the gender ratings, the accessibility and affordability. A lot of women did not have that access, even if they've been pregnant sometimes. They couldn't get coverage. They had a child before. I talked to a woman a while back. She had a lot of trouble getting coverage, and we were trying to find out why. She tried at least 5 or 6 insurance companies, and this was just before the Affordable Care Act. And what we later found out, as much detail as we could, was that this woman had her tonsils taken out when she was 16 years of age. Now that is the kind of thing you would never think about, would never imagine. But those are the kinds of things that were going on prior to the passage of the Affordable Care Act. And they all come down to how we define pre-existing conditions. So your uninsured rate for women were higher, and that's largely because some women stayed at home. They may have been a caretaker. They may have been providing services otherwise, but basically their uninsured rate was higher for men. And because of that, then they had no usual source of health care. They go from place to place. They go over here if they've got a problem there. So they had no usual source of health care. Another area that is still very much the case is the wage gap. And I mentioned earlier about the way these counties are ranked. The higher the income, the more likely you are to have access. And so if there's that gap between man and woman, then there's going to be that gap between the insured and the uninsured. So let's see if we can move now. That may be hard to see, but I wanted to show you a little clip on these preventative services. Now, there are a ton of preventative services that you can find a listing on the healthcare.gov. But what I wanted to show you was the difference between screening rates for insured women compared with uninsured women. And if you look just at blood cholesterol up there, if you had insurance, 73% of those women got screening. If you didn't have insurance, it was like 42%. Mammograms, screening, if you had insurance, 79% of those women with insurance did screening. 43% if they did not have insurance. And chances are they may have looked at other services available in the community to be at that 43%. A Pap test, if you had insurance, 74% of those women got screening. Not insurance, 54%. So just that screening basis alone made a difference in terms of who had insurance and who did not have insurance. And also, when you look at the numbers on the right side talking about cost, it goes back to cost. 52% of the women that had insurance they did their preventative services, wherein 13% did not because it was too expensive to them. Skipping medical tests or treatment. And this is more of an update on this. There's one out there in 2008, probably is a little bit different from this one, but this one was put out by the Medical Journal just back in May of 2014, so it's more up to date. The thing that was disappointing to me is that 4 in 10 women did not know about the preventative screening under the Affordable Care Act. And so a lot of women are not getting those screenings. And this is particularly the case with Medicare enrollees. Some of them are even paying for service that they shouldn't be paying for because still there's that knowledge gap about what the Affordable Care Act provides. And this is one of those areas where I call it we need to know more, the challenge going forward. The Affordable Care Act has a number of preventative services available at no cost, and we have to stress at no cost. This was put in because women were not doing this because it was expensive. So some of these basic screenings are to be done without a co-payment, and that's what we want to stress. And some of these, I just summarized these here, but you can go and find tons of them. There are a lot more of them. But I just summarized, basically, they're trying to get at some of these chronic health conditions, so you're not showing up at emergency rooms as often. You're doing things like preventative care, cancer screenings, vaccinations, and then there's that part we have to do ourselves, a healthy lifestyle. I mean, we just can't go to the doctor and say, you need to help me lose weight. I mean, you're the person that's going to have to really decide that you're going to do what you need to do to lose weight. And that's true for all of us. We have to be partners with our medical practitioners, not just go in and say, well, I'm trying to lose weight. Do you have a quick fix? And some people do look for quick fix. Some of them look for it through medication. Some of it look, through surgery and all of that. And that's not, something that I can evaluate. I'm just saying that we do have to be partners when it comes to our health care. And I just want to highlight these essential benefits that are under the Affordable Health Care Act, because I still find that there are a lot of people that do not know it, and they may have older policies that are not covered under the Affordable Care Act that really may or may not be covering all of these. There was some controversy about older policies, and people wanted to be able to keep them. And there was the discussion about whether they should or should not. Well, that's always your right to keep what you have in the way of policies. But I can tell you, having been at the Department of Insurance for many, many years, some of those policies, if they're very old, they probably are not covering some of these benefits. So don't be confused when you say, well, gee, it says I get emergency services. If you got an old policy and you made the option to keep it, it just may not be covering all these benefits. But the thing that I want to point out on these essential benefits that has come very clear to us is mental health. And it's taken a back seat every time we talk about health. We kind of act like mental health is not health. And in fact, it is. It's creating some real challenges for us. And so one of the doctors told us a couple of weeks ago is that he see more people coming in now willing to talk with him. Physician in Miami, he see more people coming in now willing to open up. And I think that's a good thing. So those are some of the benefits that are there. You got more prescription drug coverage through particularly your Medicare enrollees. I talked about preventative services, and you've got coverage for vision and dental for young children under those policies now. And some of you also may not know, in years past, if a young child got cancer or some major disease, insurers would actually remove them from the policy, from the family's policy, and leave them to figure out what to do. That's all a part of this Affordable Care Act, which would take me all day to talk about it, but there are things in there that I think we need to keep looking at, keep learning, and educating ourselves so that we know that significant changes were made. And my member of Congress said, well, Elsie, it's really insurance reform, it's not health reform. And I said, we'll take what we can get, because I see a lot of things here that change and will make the difference, just even in basic screening for people to have access for health care. One that's not talked about a lot, and I know a lot of women own businesses, they're self-employed, and before that, they had no way to get coverage. They were running a business, but they could not get coverage. So they now have access as an entrepreneur to start their own business, even if it's just one person, or two people, or three people. And then they're not dealing with this issue of existing health problems or affordability, because they now can get tax credits depending upon the size of that business and what's available to them. So those are just some little quick background things on the Affordable Care Act, what it's doing for women, how it's benefiting women. And I thought I'd put in some update information about what happened between October 1 and March 31st. And of course, we know October 1 was a bad day for a lot of us that's tried to sign people up. The system took a nice tumble in a crash. But I tell you, it made up like gangbusters. I mean, we were shocked ourselves about what happened near the end of this, particularly in the state of Florida. Florida is one of those states that did not expand Medicaid. It came in second in enrollees to California at the end of the day. And it reduced Florida's uninsured rate by 5%, and had we expand Medicaid, it would have reduced it by 10%, just in this one state alone. That part hasn't happened yet. But you can see that there was what we call an amazing turnaround from October 1 to March 31st. And March 31st is really the tentative numbers, because we still didn't have all of the numbers from the states that ran their own exchange. So you start seeing different numbers as you go along. Here's the makeup of those persons that signed up: race, ethnicity. You can see white, 62.9%, African Americans, Latinos, and Asians. So that was as of May 2014. So it was a little bit beyond the March deadline date. So those numbers look pretty good. I don't know whether you can see these or not. I thought what I would do, and the way I determined which states to put up here, quite frankly, was they had 20% women in the state. That was just Elsa's version of how to put a few states up here. So all the states I selected have at least 20% women there. These were the enrollment numbers. And look at male, female enrollees. In every case, more women were enrolled in health care than men. Most of them selected the silver plan. Some selected the bronze plan. May or may not mean anything to you, except those are the plans where you can get tax credits. That's why a lot of people selected. And silver plans really had more variation. They had more choices. Bronze, they had some big deductibles. And if I were talking to somebody about which one to select, I would say, do you have this much money to write a check first? And if you don't, you need to look at something else. I mean, that was part of the challenge of helping some people understand what to select if they never had insurance before. I mean, they really have no clue about what you're talking about. Now, the last part of this that I thought was really significant is the percentage of people that got financial assistance as a result of this. And you probably heard the last couple of days the 2 court rulings on financial assistance that came out from 2 different courts in the same day, that if you got your financial aid from a state run, then you're okay. But if you got it through the federal exchange, we may just take it back from you. Of course, we always have these challenges with the Affordable Care Act. But I just wanted you to see, for example, I'll go to the next slide. They're still all 20%. I stopped at West Virginia. Florida, 91% of the people that signed up in Florida got financial assistance for their coverage. And so you can see also that California was the highest. It had the largest number of people enrolled, but Florida was next. And it made a significant difference in the uninsured rate for Florida, for sure. I'm not sure about California. Again, you can see in every case, over half of the individuals that signed up were females in this enrolling process. And then again, if you didn't enroll in silver or any of those where you're eligible for tax credits, then you had to pay the full premium. So it just makes good sense that you're going to sign up for a good policy that's going to help you with your premiums. So that's just a kind of a look at what happened in there. Now, what did not happen in some states was Medicaid expansion. And I beat up on Florida because I'm from Florida, and I'm right here in Florida. And it just kind of shows you how many people could not get coverage because these states chose not to expand Medicaid in their respective places. So what happened is, yes, these people could be eligible to go into the marketplace, but they can't get any help. So if you're making $11,400, which is probably that cutoff in there, you can't pay the premiums at the full price. So this is why these people are now out there still uninsured. And what does that do? It further divides who has coverage, who have access, and who does not. And so you can see your Hispanic population was the highest risk, blacks next. And then you see the concentration of the states, Texas, Florida, Georgia, and you can also see your uninsured white adults, Florida, Texas, Pennsylvania, and then you look at your black adults, Florida, Georgia, Texas. It's a common theme running here. And so this is where you got this gap. This is what leaves a lot of people that are uninsured. Don't let me go with my time. So my challenges going forward, education and outreach. What we have is a lot of people that have enrolled, but they don't know what to have. So we got more work to do out there. We still have people that got coverage that's going to the emergency room instead of signing on to a physician. We have a number of states, I can't remember how many, a large number, that have not yet expanded Medicaid. And that was the intent of the Affordable Care Act, is to pick up people at that lowest level through Medicaid expansion and then provide tax benefits and credits to those who were maybe middle income, at least up to maybe $45,000, $50,000. So the middle income people did okay, and people at the lowest end of the totem pole, as I call it, did not do okay. The other thing is availability of the medical profession. Do we have enough physicians as we bring people in, as we increase the number of uninsureds, nurse practitioners, primary care doctors, specialists? That's a question that the medical profession talks about a lot. Prescription drugs, I could talk all day about that, but it's running away big time in terms of cost. Some of your more recent costs is saying it's exceeding the cost of hospitalization care these days. So I don't know, maybe that's something that needs to be looked at a little bit more about the drug business. Long-term care, we know that because women live longer, then the majority of the residents in long-term care are women, something like a 70-30% ratio across the country of male, female, and nursing home. Same thing applies for home health care. So we can see the cost and the care and the need to pay attention to women in that respect. And the long-term care component of the Affordable Care Act fell apart way back there because they did not even, they had no way to finance it or try to address how to deal with it. So it was removed from the Affordable Care Act. I think some states may be doing some things in that regard, but federally, it's just not there. Understanding health and wellness, and that's what my partner is going to talk about. She's going to talk to you more about these numbers and what I'm talking about. And so she's going to be coming up later in just a few minutes. And the other thing I have is litigation, because we litigate the Affordable Care Act every other day. There's something going on. It's either the this or the that. So it's always a challenge in what we do, what we talk about with the Affordable Care Act. But I've shown you the numbers. I've shown you what people are interested in and what they want. So it does suggest that people are interested in having access to health care. And with that, I'm going to take my seat, and now you're going to hear the other part of health care. Thank you.
We're going to have questions at the very end, if that's all right?
Well, if it's an urgent.
Or unless you want to. Go ahead.
Are there handouts, was the question?
We have a few.
I don't have a full handout. What I can do is I can email my presentation if you want that. But give me your card so I can make sure I send it to you.
Or pass a paper around or something, yeah.
Yeah, and I'll be happy to email everything that's on it to you. Thank you. You're welcome.
That was very informative. It's isn't it a pleasure to hear somebody talk about the Affordable Care Act in neutral? When she said we litigate it every day, but we litigate it with outrage and upset and fear and loathing, and people never get real information. So thank you. I really enjoyed your talk, and I think it was a wonderful contribution to people's understanding. Well, I'm Judy Sedgman, and I work in the mental health field, but I don't call myself a mental health professional. I call myself a mental health educator, and I can tell you why. Because if you are how many people here are in the mental health field, are psychotherapists or psychologists or one? Okay, well, I'm sorry. But no, I'm sorry to single you out. I didn't mean for there to just be one. But here's the difference between what I do and what the field defines itself now. If you talk to people who are in mental health, and I have a lot of very close friends who are, they can tell you everything you want to know about mental illness. They can tell you, the whole 485 diagnoses that are prevalent in the Diagnostic and Statistic Manual. They can tell you the pathology of people's suffering. They can tell you the pharmaceutical panoply of things that are available to help people. They can tell you I think there's several hundred different approaches to mental well-being that are used, cognitive behavioral, REM, all kinds of therapies. But they have a really hard time engaging in a conversation about mental health because the profession is trained, and I was trained too because I have a doctoral degree in educational psychology, so I know that. The profession is trained to address the problems of people that are struggling psychologically. So it's just like if you're a cancer doctor, you really don't have much to do with people that don't have cancer. And if you're a mental health professional, such as the field is defined now, you don't have that much interaction except personally and in your real life with people who are experiencing vibrant mental health. So when I got involved in the work that I do, which is under the rubric of innate health, INNATE, we do work in jails, and so a lot of people think it's inmate health, but that's only one of the many places we work. Innate health, it addresses what defines the experience of true psychological well-being and peace of mind. And that's why I'm a mental health educator, because I don't teach people, I don't talk to people, I don't work with people about what's wrong. Deeper than that is what's right, and the strength that you have to draw from, and the resiliency that is innate to all people, that is our birthright as human beings. And it's an interesting field because I didn't start out in mental health. Trust me, I was a newspaper reporter. I was an investigative reporter for the St. Pete Times. I was an editor. I was a business person. I started a health practice management company, and I stumbled into this field. But when I stumbled into it and I saw the power of addressing mental well-being with people before they start having problems, it's a prevention and an educational tool. I saw that we could transform the world if people truly understood the power that they have to be mentally well no matter what. And I think to a large extent, there's a lot of things I could talk about that I talk with my students about that I'm not going to bring up, but I'm going to focus on one particular thing that all women are very familiar with. And that is the role of stress in our experience of lack of mental well-being. Now, it's very interesting, and for years, nobody talked about stress ever until 1950. Stress was an engineering term until 1950. And everybody in the field of engineering understood stress to be exactly what it is, the amount of pressure or force that a material could withstand before it broke. So it's a good term for what it is, but it was adopted by Hans Selye, who was a what they call a rat scientist at Harvard, who was doing research into the effect of various stressors on rats. And, I'm not going to tell you the cruel and brutal things he did to his rats, because that was before you had all these laws about not being cruel and inhumane to animals as well as people. And he discovered that the rats didn't like them and responded badly. Well, no surprise there. You do surgery on somebody with no anesthesia, they're going to not like it. And they got stressed, and they displayed stress. And of course, he translated into, well, this is what stress is with people. So he developed a whole theory of stress, which again, I'm not going to go into. But he wrote a book called Stress, and the cover of the book had stress in gigantic letters, black and white, jiggly letters. And so it was a big popular bestseller. And it led to an enormous amount of research. So one of the first things that happened is these two researchers started looking at what causes stress in people, and they developed this list of stressors. And the list of stressors, included going to the dentist, public speaking, death of a spouse, death of a friend, loss of job, loss of your house, difficulty with children, disruptions of all sorts in life. It was a long list. And they did a national survey. There's more than 40,000 people in this survey, and they ranked stressors statistically based on that survey. And it is still the basis of all these tests that you see in women's magazines in the dentist's office when you have, you say, you answer the question, these 10 things happened to you in the last year, and then it tells you how stressed you should be, because that ranking still prevails. It's sort of like Kubler-Ross taught us all how to grieve, and now everybody's freaked out if they don't follow the steps. Before that, people just felt really bad until they felt better. So now we have stress as a really big deal. And of course, what happens when there's a big deal in public life? The pharmaceutical industry becomes very interested in it. And you can actually track the growth in diagnoses, the number of diagnoses. The first Diagnostic and Statistical Manual was published in 1952, and it had, I think, 106 diagnoses in it. The most recent one was published in 2012, and it has more than, I think it's more than 800. So, and trust me, there's a drug for every one of them. But so one of the things that's happened, part of it is research. People have refined and refined and refined. And one reason, if you think about the logic of it, which I'll get to, one reason that there are so many fine distinctions now in the diagnostic possibilities of what's going wrong with people is because people have an infinite ability to think of anything and take it seriously. And the more people observe them, the more diagnoses there are. Now, let me explain what I'm talking about. Beneath the experience of any life situation is our thinking, our use of thought. Because the only way that something can come into your life is if it comes to mind. If you think about it, that when you have tragic accidents where people pull out into an intersection in front of a car that's coming, if they had seen that car, they wouldn't have pulled out. The car was there, their head was elsewhere. There are a lot of things in life. Our life is determined by what comes to mind moment to moment to moment. If I'm snubbed by a close friend and I don't notice it, I haven't been snubbed. Too bad about her. She failed. If you go to school because you're determined, okay, today's the day I'm going to beat up the bully, and the bully is absent, you can't do it. So if it's not on your mind, it's not in your life. That's the first thing. The second thing is we are the thinkers of our thoughts. Circumstances do not make us think a certain way. Now, we've been taught that that's not true. So there are all kinds of theoretical things out there. Well, of course, she was beaten up and sexually abused as a child, so naturally she can't form a lasting relationship, blah, 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 this and that, cause and effect. But the truth is, when you look at people as individuals, you realize that many people faced with exactly the same circumstances have entirely different responses to them. So if circumstances had the power, think about it, if circumstances had the power to make us think or act a certain way, everybody faced with the same circumstances would do the same thing. And if you even watch television news, that's not true. Every time there's a natural disaster, there'll be one person in front of their house saying, oh, thank God, my dog survived, my family survived, we're together. I've got friends, we can rebuild, this isn't the end of the world, and you'll have somebody else crumpled in their driveway weeping because they lost their wedding pictures. Now I'm not making a judgment, I'm just saying these people think differently about life. And they're using their thinking differently to respond to a tragic circumstance. If you look at little children, because they're a good example of the natural way we come into life, they get over stuff right away. So I remember when I was a young mother, one of the most humbling experiences I had is the first time I left my baby with a babysitter, and I think she was about 7 months old, so that shows you how nerdy I was about, I don't want to leave her. we were going to a birthday party, and I was so flustered at leaving the baby with the babysitter that we walked out the door without the present. So we got about a half a block, and my baby was crying her eyes out when we walked out the door. So we got about a half a block, and my husband said to me, "Where's the present?" I said, "Oh my God, I left it on the counter." He said, "Well, we got to go back and get it." I was like, "Oh no." So he pulls in the driveway, and I go back in the house thinking, "Oh no, I've got to face this crying baby again." And she's there going, "Oh, hee, 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 hee." She's playing with a toy. You know, we've been gone for like 45 seconds. And I thought, oh, it wasn't about me. I didn't matter. It was her thinking, you know, something different was happening, and she could feel my tension. As soon as I was gone, she was on to her own life. So we realized that circumstances, we learn how to react to circumstances. It's a learned behavior. So when we talk about, you know, as Anila introduced me, she said, I've been working in this field basically called the 3 principles of mind, consciousness, and thought. And really what that amounts to is there is an underlying logic of human psychology which defines our psychological immune system, which is true. That's what principles are. You can't explain, as soon as you hear and understand them, they make sense, and everything else makes sense when you see it. It's just like the principles of physics or the principles of thermodynamics. When people discover a principle, you go, oh yeah, of course, that totally explains everything. I'm going to talk more about this. It's the underlying logic to our psychological immune system. Now, I've taught for the last almost 2 decades in a medical school. And so I had a lot of medical students that took my classes, and I wouldn't say necessarily with enthusiasm, but they took them if they wanted a master's in public health, because I don't teach the allopathic model. But I would say to them, look, all right, how many people can tell the difference between the living and the dead? They didn't have any problem. We might, but they don't. They know. And what is the difference? The dead are not alive, and aliveness is a feeling. It's a state. We see it. It's the light in their eyes. It's the feeling of aliveness. It's subtle movement. It's whatever. When that's gone, what we know is that there is nothing going on upstairs. The brain is flatlined, and that's one of the definitions of death. Now, one of the definitions of being alive is that there is brain activity, and you can tell that people are alive. From the time we come into life until we die, we're creating thought. Our ability to create thought is as natural to us as our ability to breathe, as our heartbeat, as our circulation, as our skin replaces itself, as cuts heal. You know, if you cut yourself, you don't have to communicate with your immune system. Say, hey, pay attention to that thumb, it's bleeding. You got to get there, get those cells there. The immune system knows what to do. There's an innate understanding within our body and soul that keeps us going. We were born to live. We were not born to have problems. We can create problems because we have free will, but we were born to survive, and we were given everything we needed to survive. We were given a beating heart, and unless there's a true birth defect, we were given lungs that inhale and exhale. We were given a circulatory system. We were given limbs. We were given what we need psychologically. And I don't know why it seems so difficult for people to say, then weren't we set up to remain at peace, to be able to keep our bearings, to have common sense, to see what to do next? Yes, we were. But we also have the will to override that. And when we override it, we get diagnosed. Now, and I'm not saying there aren't real things that happen inside people's brains. I'm not saying that. I'm just talking about this widespread issue, the people that have these, start thinking of themselves as damaged. So I'm going to state that, again, the principles of mind, consciousness, and thought. Mind simply means we're alive. The breath of life is in us. It's flowing through us. Thought means psychologically, physically, we use that energy, the breath of life, the spiritual nature of life to function. Our body is a dynamic, interactive mess of cells that are constantly in communication. So that's the energy as it plays out in the body. As it plays out in the mind, we create thought. And when we have created thought, we're set up to experience it as real. That's consciousness. We're conscious of what we created. Okay? So constantly, we're little thought machines, mind conscious thought. We just keep creating thoughts, seeing them as real, creating thoughts, seeing them as real. Now, until we learn that we can hang on to certain thoughts and see them as more real, or ruminate about them, or make them more important than they otherwise would have been, we live like children. Thoughts come and go. I'm upset, I'm over it. I wanted that toy, oh well, there's another toy. I don't like that kid, well, there's a different kid. And children are very flexible and very, they're just kind of moment to moment. If you've ever been around children, no one would deny that. Somehow, as we get older, we learn how to hang on to certain thoughts, and part of what we learn is by watching what the people we grow up with do. So a worrier is usually, if you ask them, what was your mother like? She was a worrier, because that's how we learn to worry, that's how we learn to stew and fret. But it's a learned use of our thinking, which we could change our minds about at any time. As soon as we see that we have that incredible power that is constantly at work. The principles are at work within us, that we are producing our thinking looks real to us. And when people know that, when they start to see that, they don't have to entertain negative thinking. They can, but they can see it for what it is and let it pass. And if your mind quiets, wisdom enters. The source of wisdom and insight in people is a quiet mind and a peaceful feeling. And that's available to you you're one thought away from it every minute of your life. Now, if we could teach, and my goal in life is to teach children this, because I've seen the power. I mean, I only have a limited time, so I can't tell too many stories, which is very frustrating to me. But I've worked with a lot of people in all walks of life, from juvenile delinquents to troubled families, to people in housing developments, to wealthy executives, to people who are running big healthcare companies, to students. I've worked with people across all dimensions of life. It doesn't make any difference. We're all the same. It's the human race, and nobody's winning. Humanity is defined by the quality of our thinking. And when people are in a low state of mind with low quality thinking, they make very poor decisions. They go into survival mode. They'll do what it takes to get what they need. And that's what you see in the world today. You see what I would call a very low level of consciousness, of people who are totally unaware of how attached they are to their thinking, and how thinking is like smoke. It's not cement. Thoughts were meant to come and go and serve us. But as soon as we grab something and go, this is the most important thought in the world, and if everybody doesn't see it this way, then they're stupid, we're in trouble. And really, when you see what's going on in the world today, you see people living at a very deep level of fear and insecurity, very attached to a safety net of thought that they can't let go of for fear that there's nothing there if they do, or somebody else will prevail and they'll get hurt. Now, I have never known a person who finds peace of mind who is capable of harming anything. I've never known a person at peace within who could hurt other people, the environment, themselves, the process of governance. That's not a possibility, because when people are at peace, they don't take their own thinking that seriously, and they're able to hear and listen to other people, and they're able to interact, as we just saw, in neutral. Just, talk about what's there and make common sense decisions. Peace of mind is the gateway to peace on earth, but it's one person at a time. If suddenly, and I believe this with my whole heart and soul, and I work every single day towards this end, and now because we have all these wonderful tools, we have YouTube, we have, the ability to tweet things out and reach tons of people. I do webinars now with global webinars, where the last one I did, I opened up the screen and I had somebody from Dubai, somebody from Namibia, somebody from South Africa, somebody from Morocco, Spain, France, Switzerland, the Netherlands, England, Australia. I was like, holy cow, I was talking to the world. And what was the question? The question was, how do we find peace of mind? How do we find peace of mind? The answer is, peace of mind is your birthright. It's natural. To find peace of mind, you have to let go of your thinking and allow your mind to come to rest and natural flow of thoughts to resume. It's like, how do you restore the flow of a river when there's a log jam? The logs break free and then the water flows. When your thinking is less cluttered, less jammed up, peace of mind is a natural thing. And it's there for everybody, but not everybody accesses it. Doesn't mean it isn't there. It's like the sun. We could have 40 cloudy, not in Florida, but I used to live in Seattle. We could have 40 cloudy days, but we never wondered, where's the sun? We knew it was there, we just weren't seeing it. And that's the way our innate well-being is. It's there, we just don't always see it. We lose sight of it. We lose touch with it. And the pathway back to it is quietude. Now, the thing that I wanted to tell you about stress is that after stress became this very big deal, and a whole industry was built, multi-billion-dollar industry around dealing with stress. Well, a study was done in 1999. And the study was done by somebody I know named Ron Getzel, and it was done for the insurance industry. And the purpose of the study was to determine what were the underlying cost factors in the incredible growth of healthcare costs. And when the study was published, it shocked the healthcare field. Everybody was expecting, smoking, lifestyle, all the things that we know, the usual culprits. Stress accounted for 46% of the rise in healthcare. Depression, 50-some%. Stress and depression were the two greatest contributing factors to the rising cost of healthcare. Why? Because when people are stressed and depressed, they don't take care of themselves. They don't pay attention. They can't remember to take things like go to talk to somebody about insurance. They can't bring themselves to see a way out of their circumstances. So people who live at a high level of stress and depression, not only does it have a tremendous impact on the body, and that's a whole other topic, but if you're really interested in it, there's a great book called Why Zebras Don't Get Ulcers by somebody named Robert Sapolsky, Sapolsky. He's a neuroscientist at Berkeley. He's fabulous. And this book explains how chronic stress affects every organ in the body. So it not only creates health problems, but it also creates a barrier within people's own thinking and their sense of certainty and their sense of knowing what to do and their sense of wisdom to see the direction to go to take good care of themselves and the others in their lives. So what's in it for us? To return to our birthright of mental well-being, quality of life, love, communication with the people closest to us, the ability to see ourselves as whole and all right the way we are, not as damaged goods that somebody else has to fix. It's very surprising. I see clients individually at the Women's Resource Center in Manatee County, and as a mental health educator, they're always surprised when they come in. They've been to a lot of counseling and they start talking about their past, and I'm going like, why would I want to know about that? What's in it? Well, explains everything. I'm going, no, it doesn't. It doesn't. It explains why you think about things the way you do. But it doesn't explain your life right now, because your life right now belongs to you. There's nothing wrong with you but for the way you think about what's probably wrong with you. If you could see that that's not important, you can't change the past, but you can direct the future. You can create the future. It's too bad about the past, but a lot of people have very terrible pasts. A lot of people have wonderful pasts. It doesn't make any difference. Everybody in this moment now is on the edge of tomorrow and on the edge of finding peace of mind, redirecting their life, seeing things clearly, and seeing where to go. So I'm sorry, I can't talk anymore, but I do I have a website. I have a lot of materials that are free and downloadable. If you want to give me your email address, I too can email you things or send you links. So I'd be more than happy to do that. And now I think it's time for questions.
Thank you, Dr. Sedgman, Dr. Crowell. As a physician and medical consultant myself, I use so many of the practices that they've talked about today. When they asked me to be honorary chair of this conference in the Florida Commission and the National Commission, I thought of these two wonderful women that I have known from my high school and college days. So, and I thought they would be the most wonderful individuals to come speak to you today. If you have questions, state your name and where you're from, and please stand up and ask the question, and then I'd be happy to repeat it so then everybody could hear. The question was from Ginny from Sarasota Commission, was that Dr. Sedgman didn't mention anything about meditation.
Okay. Yeah, I'd be happy to talk about that. I advocate people doing whatever makes sense to them to quiet down. And I know people that meditate that never have a moment's peace. They're sitting on their little rug and they're doing their thing and their mind's going a million miles an hour. I know other people that live their life in a meditative state. So the goal is to create a meditative state within your own mind whenever it's needed. But I have many people get tremendous benefit from meditation, but only if their head's clear and their mind's quiet. So that's the thing. That's the goal of it. And if it works for you, do it. Like my daughter, for example, she has no patience with meditation, but she does yoga, which is, some people would say, what's the difference? But, she finds that very helpful. She also is a runner. So she'll run, she'll clear her head running for 16 miles. That would kill me, but it works for her. So people have you find your own pathway to quiet. The idea is to find it.
The question was to speak a little bit more about the three principles that Dr. Sedgman spoke about.
Well, I'm not thinking of principles as in the 7 principles of a successful business or something like that. I said there are 3 principles that describe the underlying logic of our psychological immune system, and they are mind, consciousness, and thought. Those 3 forces, it's an abstraction, but they're principles. Without the energy of life, we wouldn't be alive. Without the ability to think, we wouldn't see life. And without consciousness, we wouldn't know what we see. Those are the principles. We exist, we think, and we see our thinking is real.
I'm sorry.
The question was about the 8% that were the Anglos that were in the study done in Pennsylvania about the Affordable Care Act.
I'm just not sure. The data that we got from healthcare.gov was done at the end of the month, and I believe that they're only looking at the ones that I have in that little pie chart there. And so I didn't see the Amish, so that's a good question, and it's a good follow-up one for me as well.
Yeah.
But I'm sorry, I'm not sure.
Okay.
Thank you.
I went to college in Pennsylvania, and a lot of times they don't include them because they don't access public services.
That very well may be why,
Yeah.
but it's a great question, and I'll follow up on that. Thank you.
The question is if there is a good website to keep abreast of any new changes or about the ACA Act. as it applies to women?
Yes, I have on the end of my presentation some websites. And if you give me your card or something, if you look at those websites, it goes specifically to each of those topics that I have there. And it'll tell you they got very good detail on women, as well as the what we call the exclusions in each of those states. You'll see very detailed information about your particular state. So if you give me your card, I'll be glad to send that to you. Thank you.
The question was about physicians who are not accepting patients that signed up for the Affordable Care Act and through the exchanges, and what could be done about that.
I think in that case, they need to contact their insurer. For example, if they enrolled, I give an example, Blue Cross, they need to contact Blue Cross because those particular companies have those contracts with those doctors or medical facilities, and they are paying them to service the patients in that contract. So if you get a call that says, this doctor will not see me, they need to call that insurer. Whoever signed that contract, wherever they enrolled, that would be the response. But I've heard doctors say they, particularly in Dade County, that they see a lot of people coming in to see them because of the ACA. So it just differs from one area to another, I imagine. Is that for ACA? The question has to do with the knowledge gap, knowing how to explain or help consumers really understand what they have, understand the ACA. It's a great question. It's a question that we have asked ourselves, particularly I was a state navigator, and I can tell you there is a huge knowledge gap out there. The enrollment came really fast. A lot of people purchase plans. They still don't really know what they have. We have talked to HHS, Health and Human Services, about providing more funding, particularly in this next cycle, to get more people out there that can actually help people understand what they have. I think one of the things that commissions can do is they have what we call champions of coverage. And in that, the Health and Human Services group gives you all the information that's going on. They give you, I mean, you can even be trained yourselves. You can have commissioners trained to those that you think would be interested to better understand what is going on and how to communicate with consumers. They've done training with groups. Some of them are paid, some are not paid. The best way to get paid is to try to get a grant from Health and Human Services. But Champions of Coverage is a one way that you can help others in your community. And it's more unique for your community because, for example, in Miami, you may have 12 different options in terms of an insurance company. You get in the Panhandle, you may have 2. So I only need to be able to talk with you about what United Healthcare, a couple of others offer, what's in those plans, where in Miami-Dade, Broward, you may be looking at 15 or 20 different plans. So it varies by your community. By being champions of coverage, you're looking at what's going on in your community and how you can help people. And when you hear these kinds of things, they give you a number, they give you an email to say, send those questions to us, or call us and we'll help you with the example that you gave about your doctors not taking patients. But that's clearly a relationship between that insurance company and that doctor. When someone signed up and paid their premiums, then they should be calling that insurance company to get assistance with that. Well, one of the things we learned through this earlier rollout is how to communicate with different groups. For example, in minority groups, they want one-on-one conversation. They don't want you to tell them to call the toll-free number and get information. And they don't want you to tell them to go to their computer. Some of them don't have computers. And sign on their email, they don't have emails. One of the challenges we found in some counties, you got a literacy issue. Some people really can't read. And when they do, they don't understand what they're reading. So you got to look at the uniqueness of the population that you're dealing with. And even Health and Human Services, from some of their surveys, told them the best way to get people enrolled, people of color, African Americans, Latinos, you got to have a place where they can come in and sit down and have personal conversations with them. Yes, it's time consuming, but you don't want to lose them in the process. You don't want them to sign up and drop it 2 months later. That doesn't do any of us any good. So I think you have to look at your community, look at your literacy level, telling people to go turn on their computer and sign up when they don't have one. It doesn't do anybody any good. So I think you have to look at your community specifically. Tell them to hang in there. We found out near the end that a lot of people didn't even know they could get tax credits. Some people have a full coverage insurance policy for $2. Some people have full coverage for $5. They did not know that. They will go on and look or try to figure it out, and they'll see $350 and they'll say, no way. Maybe that policy was $350, but depending on their income, depending upon how many people in that family, that very same policy could have been $25. And as people start to understand the whole business of tax credits, I think I showed you where 91% of the people in Florida got financial assistance to get coverage. They started signing up, and that's where you start seeing the big boom near the end. But the education part was slow. It was sluggish. There were not enough people out there to help people in these various communities. I mean, even in the Panhandle, you have 1 or 2 people trying to cover 8 or 10 counties. It's just too much. So hopefully they're putting more money out there. I know they're aware of that knowledge gap, but we just kind of have to keep working at it and to talk to people about their health. We looked at how many people that are uninsured and their health status, how it affects them. You've had bankruptcy situations that's largely driven by health care. You've had liens on people's property from the hospital, and yes, they can put a lien on your house if you've got one. So there's a lot of stuff that relates to health care, and we were talking a minute ago about mental health. We're looking at now 30–40%, they're saying, of people with mental health issues are in the criminal justice system. They're in prison, they're in jail, not necessarily because of crime, but because of health. So you got finance and all of that. So I think trying to zero in on your community, one group at a time. You know, if you've got an organization out there that can do some training, participate in training, have somebody come and explain what's going on. It is not easy, you're right. It's largely an insurance issue too, and that can be tough for some people to understand. They'll walk up and take the least expensive policy, and I was like, no, that's not what you want. Because look at this deductible here. Look at this co-payment. That is really a different kind of language for some people. So you got to be knowledgeable enough to help them, work them through the process and explain to them why it's important, not only for their financial protection, but their health, their well-being of their family, and everything else. So it's a lot of work. We just have to stay at it. Maybe it's a priority for some organizations. To take on and become champions of coverage.
Thank you. I know that right now what we've been talking about, education is such a key factor in these individuals learning about the Affordable Care Act. Just in Florida, with our 67 counties, what's good in one county will not be good in another, and looking at the demographics and your makeup of minorities and everything. But I think the most important thing, across the board, nothing's going to work for everyone. But for most of the minorities, the Hispanic and the African American, that face-to-face contact is the most important thing. They do not feel comfortable, like Elsie said, they do not have the computers, and they like the literacy factor. To have somebody that can answer their questions, you know, face-to-face is the most important thing. And I'm hoping that the next time around will be a lot more organizations that will take on this very important project and work with them. I appreciate you all being here. I want to thank Dr. Judy Sedgman, Dr. Elsie Crowell. Thank you so much.